So I want to thank everybody for coming tonight. We have with us Dr. Meagan Gray, one of the hepatologists here. Dr. Gray, if you could introduce yourself since this is your first time with us.
Yeah, absolutely. I've been at UAB. This is starting my third year, so absolutely loving it so far. But I kind of did my training all over the place. I was in Charleston, South Carolina for my residency, and I did my GI and transplant fellowships in Cincinnati. And then I came down here, and it's been awesome. My interest kind of within hepatology is fatty liver disease, and those of you who know me know that I'm vegan, so very into nutrition and prevention of disease with diet and things like that.
I got to say, one of the mistakes I first made when I met Dr. Gray was I knew she was from Cincinnati, and I asked if she liked chili, so that did not go well. But I also want to welcome Sabina and Narjes. If you guys could introduce yourself, they're going to be our discussants for tonight.
Hi, can you hear me?
Yep.
Hi, I'm Sabina. I'm a third-year resident at medical training or medical school in Toledo, Ohio.
Awesome.
Hi, my name is Narjes. I'm a third-year general medicine resident from Buffalo, New York.
Wow.
Well, we're glad to have you with us tonight. My name is Sean. I'm one of the chiefs at UAB, and Steven's going to be running the board, giving me a break tonight. So for our chief complaint tonight, we have a 45-year-old male who presents with fatigue and itching for 3 months, and he has the following set of liver function tests. He has a protein of 4.9, an albumin of 1.6, total bilirubin of 27.8, a direct of 23.9, AST 147, ALT 130 or 152, alk phos 1,249. So Sabina, Narjes, could you tell me what looks wrong and what do you think about this?
No, so I'll start. So when we when I see these lab values, the things I'll think usually with the liver, is it from the liver or just is it a vascular injury or it's cholestatic injury? Like cholestasis kind of looking picture. So this is mostly cholestasis pictures because the bilirubin high like to 27, and also the alkaline phosphatase is like 1,000. The it's like the AST, ALT, they are elevated, but I would think it's more they are mildly elevated. So I would think it's more like cholestatic picture.
Sabina,
Yeah.
what else do you think?
So it's interesting that the protein looks almost elevated in 4.9, although the albumin is a little bit on the low side. I'm not really sure what to make of that. I would think like the synthetic function of the liver isn't doing too well with that number. I kind of agree. It is more of a cholestatic picture. I know you usually calculate kind of the R factor, but it looks like a direct hyperbilirubinemia from what I'm seeing. The LFTs are mildly elevated, but not enough that I would consider this more hepatocellular, and the ALP is very, very elevated. So I'm thinking more cholestatic picture, kind of wondering if there's an obstruction or an infiltrative process going on.
Yeah, I think you guys hit the nail on the head. It's definitely a cholestatic picture. There's not one normal lab there that they've showed us, so everything is off. But certainly I agree with you that the bilirubin and the alkaline phosphatase are the most impressive abnormalities that we see. So, a total bilirubin we would expect to be around 1, so 28 is significantly elevated. And when we see that coming mainly from a direct, mainly direct instead of indirect, we do think that that's most likely, a hepatic process that's causing that. And then like you guys said, so AST and ALT are definitely elevated. So for men, when we're thinking about ALT levels, we want the ALT to be less than 30. And in women, we want the ALT to be less than 19. So these are significantly elevated. Though I agree with you, not nearly as much as the bilirubin. And then really the total protein and albumin are both low in this setting, which may be an indication that the liver is not producing proteins like it should, so some synthetic dysfunction.
Okay, so it seems like we're all thinking that this is kind of like a cholestasis type picture. Kind of the next set of information I can give you is some historical information. So what kind of history would help you narrow down this case?
Yeah, Sabina, why don't we have you go first for this one?
So I'd want to know what medications the patient is taking. What kind of the HPI is? Are they having abdominal pain? To think about, like, is there a stone with like a cholecystolithiasis picture maybe contributing to this? Have they had weight loss? Are they jaundiced? I mean, I would imagine they would be jaundiced with that level of bilirubin. But kind of looking for where is the obstruction in the pathway? Is it a stone? Is it a pancreatic malignancy? And kind of medications. That's where I would start.
Okay. How about Narjes? Any
yeah,
additional?
So I would think if they have any skin rash, if they have any joint pain, thinking of autoimmune process with also like elevated bilirubin, if they have like primary biliary cirrhosis or like sclerosing cholangitis. So I'll get more review system. Basically, I'll ask them everything in the review system to get more history of any sort of exposure, travel history, their social history too. So I'll ask more questions.
Yeah, I think those are absolutely excellent places to start. I think one thing that's really important is this painless jaundice, or this is jaundice with pain associated with it. So definitely, are they having right upper quadrant pain? Because that changes your differential quite a bit. You know, pain, you typically think more about stones and things like that, whereas painless, of course, malignancy becomes worrisome. Other sort of differentials that I would think of, I mean, I think that pancreatic malignancy is an important something to think about. You know, cholangiocarcinoma would be another malignancy that could definitely present like this, especially in the setting of weight loss or any of those other systemic symptoms. This could be end-stage primary sclerosing cholangitis. Definitely once those diseases progress, you know, patients do start to become jaundiced. So it could be, definitely could be late stages of PSC. And then, as you mentioned, drug injury, I think that's extremely high on the differential, especially for a young person. I think it's, you know, increasingly common that we see patients taking over-the-counter supplements, you know, which can very commonly cause this type of significant cholestasis. Other, you know, antibiotics, other prescription medications can do this as well. So definitely, and usually when we think about drug injury, we think about drugs that have been taken up to the last 6 months. So not even just something that they took a week ago or 2 weeks ago, but to develop this significant cholestasis like this, it's likely been going on for quite a long time. And so you want to ask about medications or herbal supplements up to the last 6 months. And then, you know, other things, I guess, that we always think about causing high bilirubin levels that I don't think is the right answer in this patient, but, you know, alcoholic hepatitis is also something that can present with significant jaundice. But, you know, in that patient, you would think about having, you know, a high AST to ALT ratio, which we don't see here, and usually not that significant elevation of ALK phos, but just other things to think about.
So I heard a lot of good points. I'll make it a little bit easy. He doesn't take any medications, hasn't had any medical contact for the past year. The only supplement he takes is a daily multivitamin. And then I think the next thing I had heard asked about was abdominal pain. So he says that he has had kind of just this generalized abdominal pain that'll come and go. He doesn't like to use the word pain. He just says an ache that occasionally feels like a cramp, and he can't tell any associations, doesn't have associations with food or exertion. He did not have any joint pains. And then in terms of like any weight loss, he hasn't noticed any, but he thinks his clothes may be fitting a little bit looser. He has felt some fevers occasionally, as long as he's been feeling this itching. And then I had also heard some questions about like travel history. He's from Alabama, hasn't traveled outside of Alabama. For his social history, he is single. He denied any sexual partners to us. He does drink alcohol, 2 to 4 beers per day, about 3 to 4 days out of the week, and then he denies any sort of recreational drug use.
All right, well, that narrows your differential some. So what do you guys want to do next? Or what are you thinking after hearing that additional information?
So I would think it's mainly like painless. We can say jaundice because he said it's ache. It's not an acute pain. So if it's not acute pain, we'll think it's more malignancy, something more chronically processed going on. He noticed this fitting loose. So he didn't plan like to lose weight or anything, but sometimes people will just notice like their weight change. If it's not like significant, sometimes just on when they are like their usual clothes, it's not fitting them anymore. So we rule out infectious causes with he's not like having any like I would rule like any hepatitis, the usual infectious processes rule out because it's been 3 months. So I would think this is more chronic process. So malignancy would be top on my differential right now. His drinking history is not really significant, so I'm not thinking anything like alcoholic hepatitis or even like liver cirrhosis or chronic like liver condition. This is more like I would think malignancy like right now it's the top of my differential. So we'll get more history, maybe vitals and examination.
Yeah, Sabina, any other thoughts that you had?
Yeah, I kind of agree with that. I think it's most likely malignancy. I don't know if infiltrated processes present like this, but something like fungal, bacterial, like TB, I don't think are very likely in this patient, but probably lower down on my differential. I've never seen it present this way, but just a thought.
Yeah, I think for someone who's from Alabama and we're not really getting any history of being immunosuppressed or anything like that. So I think that infection is lower on my differential. I guess the other thing that I would include, which would go along with the malignancy category, there is, some patients who have lymphoma can develop a cholestatic hepatitis as a paraneoplastic syndrome related to lymphoma. And so that, can present like this. You're kind of tempted to think it's just infiltration of the lymphoma, which certainly could do this as well, but it can be lymphoma not in the liver, but just as a paraneoplastic syndrome. But I completely agree with everything you're saying. I think, just as a reminder, normal alcohol limits for women are no more than 1 drink a day, and alcohol limits for men are no more than 2 drinks a day. So the alcohol is a little bit more than we would like to see, but I agree with you. This isn't something he's doing every day, so unlikely that this is alcohol related. And so I completely agree that malignancy remains extremely high on my differential for this patient. So is there, would you want to do a physical exam next, or maybe obtain some imaging, or?
Give you whatever you'd like. I think physical exam might come first, if that's what you guys would like.
In the liver world, we usually just go straight for the imaging.
That's true. So on physical exam, he had normal vital signs, heart rate was in the 80s, blood pressure was like 110s over 70s, had a normal pulse ox on room air. He appeared to be comfortable. He did have scleral icterus. He was African American, so it was hard to tell if he was jaundiced, but he quite evidently had scleral icterus. Did not really have any abdominal tenderness on exam, could not appreciate an increased liver span, did not palpate the spleen, didn't see any stigmata of cirrhosis on exam, so like no pulmonary erythema, no spider angiomata, didn't really have any gynecomastia, did not have any edema either, and his lungs were clear. JVD was normal.
Okay. All right, does that help you guys at all, or not really?
It sounds like more of an acute process than, go ahead.
No, no, go ahead.
It sounds very acute, given that he has no stigmata of liver disease or kind of the things you would expect with cirrhosis on exam. That would just be my one thought. So maybe something like cholelithiasis, but I still think malignancy may be on the differential as well.
So I guess when you're saying acute, is there a timeline that you associate with acute? Like you're saying maybe several months, or you're thinking several weeks, or?
I don't know exactly, possibly several weeks.
Okay. Yeah, I think that I agree with you. It doesn't sound like he has stigmata of chronic liver disease, so cirrhosis may drop down a little bit on our differential, but some patients don't necessarily have those stigmata, especially in African Americans, which we don't know this patient's race. So that doesn't necessarily rule that out. But I do, when we're, especially if you're thinking about sort of infiltrative diseases, which was something you had brought up earlier, we may expect to be able to feel the liver edge on our exam, which we, weren't able to do. So, so that may make that a little bit less likely. But otherwise, I think that, a lot of the exam stigmata from cirrhosis comes from, that being a high estrogen state, like the pulmonary erythema and spider angiomata. So, it may not have been going on long enough for the liver to stop clearing estrogen for that to be an issue. So would there be a next test that you guys think would be helpful?
Other blood work will help, like CBC and see if he has like an anemia, will mean like malignancy or something, like something will direct us more towards the diagnosis and imaging.
I guess what would you expect to see on a CBC that would help you with the diagnosis?
So if I think like maybe he has like malignancy, sometimes we'll see anemia with it, or like I'll see thrombocytopenia sometimes. If it's lymphoma or leukemia process, we'll think like they will have like leukopenia or leukocytosis too. So it depends. It will help me differentiate what sort of malignancy. If I'm thinking pancreatic, maybe the CBC would be normal. If they have like malignancy, sometimes anemia as a paraneoplastic, also like a lot of patients, malignancy patients, they will be anemic. So if they have maybe they will have like some malabsorption with pancreatic cancer, that would be like also like have anemia. This is like a long way like to get to there, but it could be. It will narrow the differential. I mean, with the examination right now, it's narrowed. For me, it's more clearly malignancy. I think it's more like because he doesn't have any tenderness, no like hepatosplenomegaly, but splenomegaly also we cannot see unless they are like 3 times the big of the spleen. Like you can appreciate it in examination. Hepatomegaly, sometimes if it's infiltrative process, as they said, that would be on the exam. But also if the patient obese, because we don't have the BMI here, we cannot hardly assess their hepatomegaly like during the examination. But I think it's rule out other things, and also the vitals are stable, so the patient's not really sick. So we have time like working up.
Sabina, what do you think?
Just kind of some things that were brought up in the chat I think are pertinent. The ALP is quite high compared to, I understand the Billy's high, but it does stand out. So I know LFTs may be mildly elevated in other malignancies as well, and they make like ALT is more specific to the liver, but there can be other malignancies that can raise the LFTs. So I don't know if I'd want to get a GGT in him as well, or a 5-nucleotidase, I think is another test that can be done. And also get maybe a PT-INR just to see further the synthetic function of the liver.
Yeah, so I guess to start with your comment about GGT and 5-nucleotidase. So those are tests that so typically the situation in which we find those tests valuable would be a patient who has an isolated alkaline phosphatase elevation with completely normal liver tests, and you're not sure if the alkaline phosphatase is coming from the liver or potentially somewhere else, because alkaline phosphatase can be produced in the bone and other places. And so to confirm that an isolated alkaline phosphatase elevation is indeed coming from the liver, a GGT or a 5-nucleotidase can be very helpful. In this situation where all of the liver tests are high, we can feel comfortable saying that this is coming from the liver. So I don't think that that would provide any additional value. And then I guess to go back to the comment about the CBC, I guess I would argue that I don't think that would be helpful. I think that as you were describing why you were wanting the CBC, you kept saying because of malignancy, because you're concerned about malignancy and it might point you towards malignancy. And I think we're all very much thinking about malignancy at this point. So my next step would definitely be to get imaging. I think the INR is valuable. Certainly an INR can also assess liver synthetic dysfunction. We're not given any history that the patient is having encephalopathy. So in terms of thinking about things like acute liver failure, he doesn't seem to be in acute liver failure based on his mental status being clear. And so while I think an INR is valuable, I'm not sure that it's going to help you get to your ultimate diagnosis. So personally, my next step would be imaging. And so there's a few different options. You know, most people would start with an ultrasound just because it's the least invasive or, you know, least expensive option. But MRCP is an excellent test to assess the bile ducts within the liver. And so if you're thinking about something like PSC or cholangiocarcinoma, an MRCP is extremely helpful. You know, pancreatic malignancy can be very well assessed with a pancreatic protocol CT scan. So I think there's a couple of different images that could be helpful. And, you know, I think we can start wherever you want to start, but I think that imaging is definitely kind of the biggest bang for our buck in terms of making a diagnosis.
Well, I can start with an ultrasound, and I am very curious to hear your all's thoughts once you hear the report on it. But the ultrasound of the abdomen showed a normal liver, no splenomegaly, no evidence of dilated biliary ducts. There was no stones in the gallbladder, no evidence of cholecystitis, and the pancreas was not well visualized due to overlying bowel gas.
All right, guys, so what do you make of that?
Oh, I want the MRCP right now.
All right, Sabina, what about you?
Yeah, I agree with that.
Yeah, so there definitely can be biliary disorders that don't show up on ultrasound, and so I 100% agree that additional imaging is warranted. I think that when you come to the situation where there's no clear evidence of duct dilation or obstruction, there's kind of two pathways you can go, and I kind of do them both simultaneously most of the time. So MRCP is excellent to get a very good look at the bile ducts within the liver. So certainly you can have beating of the intrahepatic bile ducts on, you know, as in PSC, which may not show up on your ultrasound. So definitely an MRCP would be a better way to diagnose PSC. But I also think that a liver biopsy becomes very important in this situation. So when you're thinking about drug injury or I guess drug injury being the most common, but also things like small duct PSC, where PSC affects the very small ducts in the liver and isn't necessarily apparent on imaging, or even things thinking about like our paraneoplastic syndrome from lymphoma. Those things would be better picked up on a liver biopsy. So I really think this patient needs both. And so I would kind of move forward simultaneously doing both of those things.
Dr. Gray, in the chat, there's a lot of discussion. So when we were talking about MRCP, there was some discussion about would you get an ERCP, and then people are also talking about EUS and biopsy. Can you comment on maybe whether you would consider those or how those might fit in here or in a different case?
Yeah, absolutely, for sure. So I think that if you had clear evidence of biliary obstruction, then definitely ERCP is the best next test. So unfortunately, so far, our ultrasound has not given us a clearly defined biliary obstruction diagnosis. So I think that jumping to an invasive procedure next may not be the right thing to do. An ERCP can also be used to diagnose things like PSC. You know, ERCP, MRCP are equivalent in diagnosing PSC. However, we typically go with the non-invasive option first. And similarly with your EUS, so if you're concerned about biliary obstruction and you're not exactly sure where it's coming from, you think potentially there could be a pancreatic mass, or I guess that would be kind of the main thing on your differential, then EUS is definitely the best next test. So I think if we get our MRCP and it shows something drastically different in terms of there actually is duct dilation that we didn't see, or your pancreatic duct is dilated, and there's, excuse me, and there's suspicion that there might be a mass in the head of the pancreas and we need to get a better look at it, then absolutely EUS would be the best next test. But right now we don't have any evidence of obstruction right now. And so we still need to get a little bit better idea of what's happening before we do an invasive test.
So I think I'm hearing calls for an MRCP. And unfortunately, the MRCP was one of the most unhelpful reports I've ever read, I think.
Uh-oh.
It said that there was slight intrahepatic duct dilation. They did not see any evidence of strictures, no evidence of stones. There was nothing wrong with the pancreas. They didn't see any sort of mass, no cysts. So it looks like there's not too much going on here other than elevated liver enzymes. What would you guys like to do next?
What do you think, team?
Is it like, can we go like for liver biopsy in this condition? If the patients like continue to, I mean, he's symptomatic, his liver enzymes elevated, we don't have a clear, or we can like look for other autoimmune process, like check their lab.
Yeah, I think
I'm not,
no, I think that's
lost
great. Yeah, I kind of said I kind of go down both pathways at the same time. So I agree with that. I also would just say that unfortunately we do see a lot of MRCPs done in the community that are of poor quality. So when we do get outside reports like this, I always make sure that our radiologists review the imaging and make sure it was good quality and that sort of thing, just to make sure that nothing was missed. We've definitely had patients come that have had masses and had PSC and all kinds of things that were missed by outside radiologists. So kind of confirming that it was a good quality image, I think, is very important. I assume you're going to tell me this was done here.
Oh, you're right. This was done at an outside institution. So I'm laughing on the inside because you've been spot on so far. But I've heard some calls for labs, I guess. What labs would you like?
I mean, we didn't check like, I mean, it's not autoimmune hepatitis, but anti-smooth muscles, one of the things I would look for, ANA, those things I'll look for. I can't remember the one with the primary sclerosis cholangitis. I cannot remember which one was with that. Because I feel like liver biopsy would be invasive procedure. So we should rule out things and maybe repeat the MRCP if it's like that's an issue, like if you get it from outside facilities, or like check the imaging with different radiologists, like we read. I mean, those things really can happen. Like sometimes stuff can miss. So maybe reviewing the imaging. So
yeah, I'm looking at through the chat now. I had been ignoring it, but yeah, lots of calls for labs. So I guess just to comment on some of the laboratory tests. So when we think about chronic liver disease causing this picture, I guess I would say a couple of things. To comment on PBC, you know, PBC is a disease of the small intrahepatic bile ducts that is not evident on imaging and requires either a positive antimitochondrial antibody or a liver biopsy for diagnosis. It would be extremely rare. I don't think I have ever seen PBC cause a bilirubin of 27. So just from experience, I would say that's extremely rare. From an autoimmune hepatitis standpoint, so if you have a first presentation of autoimmune hepatitis or even sort of a flare of autoimmune hepatitis, and those patients maybe have never been on medication or have not been taking their medication, you can get significant hyperbilirubinemia associated with that. But there's also significant liver necrosis and hepatocyte death occurring in that setting. So if you were saying that the bilirubin was secondary to autoimmune hepatitis, you really should see AST, ALT over 1,000 or significantly elevated. Granted, these are high, but to fit with a bilirubin that high, this would not fit a classic sort of autoimmune hepatitis flare picture. So I guess, you know, of course, if this patient was being seen in the hospital, I guarantee you that all of those things were checked. But in terms of what's high yield and what's likely to lead us to the diagnosis, I don't think that any of those things would be helpful, though I don't think it's wrong to check them. And that would go along with some other people were mentioning, you know, ferritin levels and viral hepatitis, alpha-1 antitrypsin. If you have liver disease that is so decompensated that you're mounting a bilirubin of 27, then you need to have ascites and, you know, variceal hemorrhage and splenomegaly and all the other signs of portal hypertension. You know, you wouldn't expect just sort of the liver test abnormalities with no other signs of decompensated liver disease.
So I'll give you those labs, and we had uploaded the MRCP to our imaging system. The radiologists agreed with the report. They said it was of great quality. So they did agree with the report from the outside. And then the ANA was negative, AMA was negative, ASMA was negative, HIV, Hep B, Hep C was negative. His ferritin was 2,400. His iron was 29. TIBC was 284%. Fat was 10%. And then his IgG total was 418, and his IgG4 was low at 3.7.
What about
and I'll give you his INR was 0.9.
All right, guys, I'll let you take a stab at those first. What information or how has that helped you? Or not helped you? Sabina, you want to start?
Sure. The first thing I thought of was the IgG4 seemed low compared to the total IgG. Not really sure what numbers to expect if there's an IgG4 related liver disease. The ferritin was higher, I think 2,000. The iron sat was low, which is like an iron, almost consistent with an iron deficiency anemia. Yeah, but I'm not really sure how to interpret that further.
You're allowed to call for help.
I think the ferritin is like acute phase reactants. It's high. I think that's the reason why it's high. So I think they were looking for like hereditary causes like hemochromatosis, but this doesn't fit the picture at all. To be honest, I'm not sure about the IgG4, why it's low. The INR is normal, so this is like, so it's not decompensated liver disease, so a lot like liver cirrhosis. I mean, the imaging told us the liver is good, like normal looking. The hepatitis, the rollouts like infectious causes, viral hepatitis, and the autoimmune would roll out with the other assays, like normal, the other like the ASAMA and the ANA were negative, so that's roll out their autoimmune. So I think at this point, maybe we need that liver biopsy.
Yes, I would agree. So yeah, IgG4 related disease certainly can cause a cholestatic hepatitis, but you would expect the IgG4 to be high in that setting. And then our autoimmune markers are negative. And then, as you said, the ferritin of 2,400 can be an acute phase reacting. You know, ferritin is stored in macrophages, which are likely releasing ferritin in the setting of severe liver injury. So the percent saturation that you want to look for in terms of things like hemochromatosis, the cutoff is a transferrin saturation of 45%. So with the transferrin saturation being low, you're really not thinking about things like hemochromatosis, which we weren't really thinking about that anyways. And then a couple of people brought up things like HLH. I usually don't think about HLH with a ferritin of 2,400. You start saying like 10,000, then absolutely, but 2,400 would be low for me in terms of thinking about HLH. So I completely agree. I would do a liver biopsy. I still think there's a possibility this patient could have, like we talked about, like a paraneoplastic cholestasis from lymphoma. So probably would go ahead and just scan his chest and look for, other places where there could be enlarged lymph nodes at the same time. If the liver biopsy is related to a paraneoplastic syndrome, you're probably going to see loss of bile ducts, so like a vanishing bile duct type syndrome, which can explain your liver test, but still ultimately doesn't give you a definitive diagnosis. So I would kind of be doing the biopsy plus getting some chest imaging, making sure we do a really good physical exam for lumps and bumps and things like that.
So he did get some chest, abdomen, pelvis imaging with a CT. His liver and spleen were normal on that again. Pancreas was normal, bile ducts normal. However, he did have enlarged pericardial, para-aortic, and retrocaval lymph nodes measuring up to 4 centimeters. He went for liver biopsy, and I can pause right here if you would like to kind of talk about this more, but I think Dr. Gray, you've kind of already been mentioning what you think it is. So he underwent liver biopsy, which did show the loss of interlobular bile ducts and greater than 50% of the small portal tracts, which was consistent with the diagnosis of vanishing bile duct syndrome. He also went and got lymph node biopsies and was found to have classical Hodgkin's lymphomas. He had mid-cellularity type. He, because of his liver dysfunction, was not a candidate for the majority types of chemo, but he was started on immunotherapy. Unfortunately, he progressed fairly rapidly and went on hospice shortly after this and passed. But I thought it was a fascinating case and kind of well worth discussion because it wasn't something that I had heard of before. So Sabina, if you don't mind sharing with us, what are kind of 2 take-home points you have from this, and we can kind of all share something that we learned about this case.
So the takeaways I know I've read the transferrin sat is greater than 45%. I didn't remember that, so that's something I picked up. I have not heard of vanish. I think I've seen like in a footnote somewhere about vanishing bile duct syndrome, but I haven't actually seen a case of it or know too much about it. So that's something I'm interested in learning about.
Yeah,
Dr. Gray,
Oh.
Yeah, would you be willing to tell us a little bit about it? I know a little bit, but I'm
yeah,
sure.
Yeah, vanishing bile duct syndrome is one of those things that you just never ever want to get, but it can happen for a variety of reasons. So, medications are one cause. So in patients who do get significant cholestasis related to drug injury or a herbal supplement that they were taking, it can cause destruction of the small bile ducts. And that's considered vanishing bile duct syndrome. So there's a variety of reasons why people can get it. In the setting of lymphoma, I don't know if the pathophysiology is completely understood, but it is thought to be a paraneoplastic syndrome where the very small bile ducts are destroyed. It's unfortunate in lymphoma. I actually have a clinic patient with probably, she's still alive, thankfully, but I'm not sure that her liver is getting any better. There's the thought that if you start chemotherapy and you control the lymphoma, that the bile duct destruction will stop. The problem is once you lose your bile ducts in the liver, they're not like the rest of the liver and they often don't come back. So my patient actually has been getting chemotherapy for lymphoma. Her lymphoma is actually doing much better, but unfortunately we haven't really seen any improvement in her liver test, and she remains extremely itchy. But yeah, I'd have to honestly look it up to remind you all the different things that cause vanishing bile duct syndrome. I mean, we can, after transplant, we think about chronic rejection causing the loss of the small intrahepatic bile ducts. So that would be something else. But you guys are writing over here in the chat a couple of other things. Yeah, I mean, I guess like PSC and stuff, you do lose your small intrahepatic bile ducts. So I guess technically that would fit as well. But yeah, unfortunately, I have not seen a case yet where the vanishing bile ducts have been reversible and the patient has kind of returned to normal liver function, or liver, I shouldn't say liver function, liver test. I hope that someday a case will prove me wrong, but so far it's been a fairly poor prognostic sign.
Narjes, do you have some take-home points that you thought of along the way?
Actually, if we think like about the differential we're working from, we don't need like to order everything like usually, you know, it happens. And we were working the case in that way. We were like focusing exactly what's going on with the patient, and we were thinking, I think this is really good practice to do, other than like trying to just in case order other things. So that's my take home.
Yeah, this was an excellent case. I think it brought up a whole bunch of different points in terms of labs and evaluation and workup. And thank you for picking something that I actually got. I was very worried you're going to stump me. But yeah, I mean, now that you guys have seen this case, I'm sure you'll never forget it. So if something pops up like this in the future, now you'll think about it for sure.
I think the things that kind of to me stuck out the most was that you can have negative imaging with this diagnosis for evidence of this biliary dilatation. He actually got the CT chest, abdomen, pelvis done fairly soon when he had come in. So they had known about the lymphadenopathy, and it was actually kind of high on the differential fairly early in the course. So I think for me personally, remembering that, you know, everything is a pivot point. If you see lymph nodes, normal bile ducts, you can still have this syndrome, paraneoplastic syndrome, causing this cholestatic picture. So he was very itchy, and I felt extremely bad about his overall case, but he was a wonderful gentleman, and hopefully has kind of taught us all a little bit about evaluating cholestatic liver injury. So thank you guys. Thank you, Dr. Gray, for coming with us and helping walk us through this case.
Absolutely. You're welcome. This was a great case.
I believe next week will be a BMP case, if I remember right. So we look forward to seeing you guys then. Narjes and Sabina, I want to thank you guys again for being good sports. Anybody who wants to be a discussant, you can sign up, and we would love to have you. We love being able to share these cases with all of you guys. So if you have any cases you think would be interesting, please submit them, because I promise I'm rapidly running out of cases in the backlog. So we look forward to seeing you guys again. Thank you.
Great job, Megan.
Thanks.